Hi, my name is Connie Flanders and you're watching the video on the characteristics of fully accommodative esotropias. So in terms of that flowchart we looked at earlier, what we're discussing is patients who have an esotropia that's accommodative and intermittent. And we're specifically talking in this video about the fully accommodative esotropia. And another term utilised for fully accommodative esotropia is refractive accommodative esotropia. They mean exactly the same thing. And so you may come across people who discuss this condition as a fully accommodative ET, and others will refer to it as a refractive accommodative ET. The etiology of the fully accommodative esotropia is moderate hypermetropia. It is refractive in nature, so the cause is purely that the patient has moderate hypermetropia. There can be a family history, so there can be a hereditary element to the condition, but the child will always have hypermetropia or a moderate amount of hypermetropia. Let's look a little bit more specifically at the etiology. So what we have is a young child who's hypermetropic, and when their hypermetropia is uncorrected, obviously they'll have retinal blur, and they can do one of two things. They can either accommodate through the hypermetropia to see clearly, or they'll make no effort to accommodate to see clearly. Now, the children that make no effort are generally those that have high amounts of hypermetropia. So say as an example you have +6 OU hypermetropia, then it's very difficult for that child to accommodate through 6 diopters of hypermetropia to see clearly. So they make no effort and they just stay blurred. This means they won't develop the esotropia because they're not doing any excessive amounts of accommodation, but it does mean that they'll develop bilateral ametropic amblyopia because the brain is not receiving clear images to develop appropriately. Okay, let's go through the child who actually accommodates. Okay, so a child who chooses to accommodate through the hypermetropia will generally have moderate amounts of hypermetropia, like a +3, +4, and they can push through that hypermetropia to see clearly. Now, obviously, they're doing excessive amounts of accommodation because at a third of a metre, they should be doing 3 diopters of accommodation, as an example. But if they've got 3 diopters of hypermetropia as well, they'll be doing 6 diopters potentially at that distance. So with that excessive amount of accommodation comes an excessive amount of accommodative convergence. And for some patients, this will lead to having an esotropia, whilst others may not develop an esotropia and generally will have an esophoria. The patient who develops the esotropia is one that generally has insufficient fusional divergence. So they've got poorer binocular functions, and this leads to a refractive accommodative esotropia or a fully accommodative esotropia. Now, it's been added here that the individual will have a normal ACA ratio. If they have a high ACA ratio, it's likely that they'll be classified differently. They won't be exactly a fully accommodative ET. We'll talk about that a little bit more later, but with a high ACA ratio, what tends to happen is we have patients with a convergence excess pattern. Okay, if, however, on the other hand, the patient has sufficient fusional divergence, so their binocular functions are strong, then they will be able to overcome the fact that they're undertaking excessive amounts of accommodation and thereby accommodative convergence, and what they'll have is an esophoria. The other thing that may help is if the patient has a low or flat ACA ratio, which means that for every diopter of accommodation, they're not doing as much accommodative convergence as someone with a normal ACA or a high ACA ratio, and this generally will lead to an esophoria or perhaps even orthophoria. Okay, so what we can see here is that individuals with a fully accommodative esotropia are developing this manifest strabismus because of the refractive error that's present. It's moderate in size, and thereby they can induce excessive amounts of accommodation to see clearly, but then that has consequences, and for them it has consequences in that they develop an esotropia. Okay, so the onset is about 18 months of age to about 4. That may vary, but that's generally about when the deviation develops. And there is some thinking that it develops more readily around that 2-3 year age range when children are starting to do a little bit more close work, such as colouring in, and thereby they're using their accommodation more than they used to when they were younger. Okay, so in terms of the clinical characteristics, clearly we expect that we're going to find hypermetropia in these patients. When you cover test them, what you will find is that without glasses, they'll have an esotropia, And with glasses, once you've corrected the refractive error, so there is no need for additional or excessive amounts of accommodation, the patient will be straight. We can see that here. Here we see that the patient without glasses has a left esotropia, and then once the hypermetropic correction is given to the patient, they are straight. And you would confirm this with a cover test. With the glasses on, they'll either have an esophoria or they'll have an orthophoria. The angle is generally basic because we have a normal ACA ratio and there is really no impact of the ACA ratio or PCA ratio on this deviation. So it tends to be very similar near and far. Now, I make a note here that the cover test must be performed with an accommodative target, and you need to get the patient to look at the lowest line possible when you're assessing the patient with an accommodative esotropia. Now, you should do this routinely, but it's extremely important in these patients because depending on the level of accommodation that patient is doing, the deviation size will vary. We can see that with the child here. Say that, for instance, this child here is either looking at a torch or at a letter or picture where they're not needing to utilise much of their accommodation. We can see that he's straight here. What this means is that he's blurred and he's not using his accommodation to see clearly. But then if you force him to look at a target that's detailed, such as letters, what you can see is that immediately the esotropia presents. And if you ask him to look at a letter that's very detailed, so an N5 print, for example, then we can see the deviation is even larger. So in order to do an accurate cover test and prism cover test, you need to be controlling that accommodation as best possible. And to do that, you need to be getting them to look at the N5 and the 6-6 line, if that's what the child can achieve. And here, again, we have the child with their glasses on. And let's assume here that the child is looking at N5 print. They are straight, maybe an esophoria is present, but when you take the glasses off and they're looking at N5 print, they become esotropic. Okay, in terms of amblyopia, generally the deviation is constant when without the glasses, so depending on how long they've been without glasses and have had uncorrected hypermetropia and how long they've had this esotropia for, amblyopia is likely to develop, but it generally is fairly mild and easily treated. In relation to binocular functions, you can imagine that in this state here, when the patient has a manifest deviation, or here where the patient has a manifest deviation, they will either be suppressing or have diplopia. In general, most children will suppress during the manifest phase. Then with the glasses on, as we see here and here, with the eyes being straight, the patient should have stereopsis, effusion range, etc. You should be able to demonstrate binocular functions. With the glasses on, because now they've become phobia to phobia, the patient may at some point become anti-suppressed, whereby when they take off their glasses, they may then notice diplopia, which is not really an issue in that these individuals will constantly wear their glasses, both because it improves the cosmesis for them and because it gives them BSV and so forth. The other thing to note is that if you wanted to, or if the patient wanted to, you could prescribe contact lenses that will have the same effect. So if the child becomes older and into their teenagehood or adulthood, if they want to wear contacts instead of glasses, they will still have an improvement in the cosmesis because the contacts obviously also reduce the need for the excessive accommodation. Okay, that brings us to the conclusion of this video. Thank you for watching.